everybody. I'm Dr. Steve Karstensen, Chief Dental Editor of Dental Sleep Practice, a MedMark publication. Welcome to an educational presentation and Q&A with Dr. Michael Pagano. In our webinar today, we'll discuss challenging cases in dental sleep medicine and progressive approaches you can apply in your practice. Associated with this presentation is a free CE quiz. At the end of the webinar, we will email all registrants the presentation replay along with instructions on how to access the CE quiz. Before we get started, I would like to invite everyone to use the Q&A feature in the control panel to ask any questions. They'll be answered at the end of the session as time permits. Now, I'm really pleased to introduce our speaker. Dr. Michael Pagano grew up in southeast Wisconsin and attended dental school at the University of Iowa, then served active duty in the Army at Fort Riley, Kansas. During that time, he worked alongside multiple dental specialists in a world-class facility, providing excellent dental care to soldiers using the latest dental technology. His clinical success as a general dentist was recognized, and Dr. Pagano was selected to train in dental sleep medicine. He established the dental sleep medicine at Fort Riley, which became one of the Army's most successful programs, and he was selected to be an instructor for Army dentists treating soldiers suffering from snoring and obstructive sleep apnea. He's lectured nationally at major dental conferences and incorporates new technology and the latest dental materials into his practice. Thanks so much for joining us, Dr. Pagano. Now, I'll turn it over to you to learn more about today's topic.
Excellent. Thank you for having me on today. Thank you for SomnoDent for having me on today. I'm really excited to talk about today's topic. Dental sleep medicine has been something I've been focused on 10 years now, and almost entirely in private practice now, about 5 years, nothing but this. So I'm excited to share what I've been learning. Certainly, I think everything has changed over the last 5 years as we're coming out of COVID, and we've really been accelerating. So I can't wait to show what we're doing and help more people get into this. I'm going to get started today. Just one thing I really want to point out here. SomnoMed asked me to do this lecture for them, and I very much purposely turned down any type of honorarium or speaker fees. This is 100% volunteer on my side. I'm not getting any financial gain for this. I really enjoy dental sleep medicine. I love sharing it with other people. So me personally right now, I have no financial interest in anything that I'm going to be talking about. As we talk about this stuff, a lot of this is my opinion. I do want to make sure that you are following all your state board rules and laws as they apply to you. So here's kind of an outline of what I'm going to be going through today. What I really want people to understand here is, a correct patient workflow for dental sleep medicine. I came into this field a little bit unique in that I came in it through the military. And that took away a major obstacle that a lot of people have as they get started with dental sleep medicine, and that's mainly the billing. So my introduction to dental sleep medicine, I hit the ground running doing 20 plus appliances right away on my first month. And I thought that was normal. What I have done on the civilian side now, or in private practice, I've taken the principles that I had in the military, which were mainly, hey, how are we going to get this done in a timely manner, and apply it to the civilian side. So in order to know what complicated cases are, you really have to have a really good understanding of what easy is. When I talk to new doctors doing dental sleep medicine, in dentistry, this is a hard concept because dental sleep medicine is more of a therapy. It's not a procedure. As a profession, we are generally very procedure based. When a patient comes in with acute tooth pain, we do a procedure and manage the pain almost that same day. With dental sleep medicine, it is not that case. There's very limited amount of times where you do something in one day and that solves all the problems. So that's something that I'll tell my patients. It's difficult sometimes as new dentists getting into that to understand this is not a one-shot go. This is a therapy. This is a process. So with that little introduction, I just want to give you a good understanding that I've done dental sleep medicine in almost every setting. I've done it in the socialized medicine world of the Army. I have done it as an associate in a general dentistry practice. I have done it as a contractor in a medical clinic. And now I've also done it as the owner in my own specialty clinic. So, from this, what I want to tell you is some of the do's and don'ts that I've learned along the way. And what I have learned with dental sleep medicine, the difference between this and your general dentistry is a lot of patients, the overwhelming majority, can be kind of managed the same way. What do I mean by that? There's a very kind of specific set of appointments that we're going to be doing, and 80% of the time, patients go through this nice flow. So, in my practice, we're going to do our new patient exam and records. If they're coming in person, they're going to get that done at the same time. If they're able to do the new patient exam via telehealth, obviously, not everything can be done via telehealth. They'll still have to come in for the dental exam and in records. Um, but some of the stuff can be done via telehealth. You'll have to look into your individual states if they allow dentistry to do that. But then right away, then we're getting into delivery. And these need to be fitting well. We'll get into that a little bit later. But your appliances, this should really almost be like a cast partial. What do I mean by that? You've got like 5 minutes of adjustment time period. If you're messing with it more than that, chances are something's kind of gone wrong or gone off. Most of the time now in my clinic, this is kind of a hand it to the patient, they put it in kind of a deal. Now, the calibration process within dental sleep medicine, it has been changing over the 10 years that I've been in it. And COVID, in my opinion, was a major disruptor in that. When I first got into dental sleep medicine, the recommendation was to deliver the appliance, call them within 24 to 72 hours, and then see them weekly until it's titrated to effect, and then send them for an efficacy study. Now, I saw practices that were doing that, and these are doctors doing it at extremely high level. It was very good care. However, it was a lot of appointments. You are talking about a significant amount of chair time and anywhere from 4 to 8 appointments to get a patient completely calibrated. That is extremely expensive. One of the most expensive things you can do in dental sleep medicine is unnecessarily eat up your chair time. So now what we are doing is, I'll get into this later, we're doing a very successful multi-night home sleep study in succession in multiple positions, which has really driven our success rate up considerably. It's also given me a lot of trust with my referring physicians, and it's reduced the amount of time I need to see people in the chair. After that, they're going to come in for 6 months, verify everything's going well, and then they're placed on an annual follow up. So, this is a very easy railroad track type of procedure. Now, in order to make sure you're going to keep everyone in that kind of 80% railroad track workflow, one of the things you have to ask yourself, who is your ideal dental sleep medicine patient avatar? What do I mean by that? This is the quote unquote low hanging fruit. That was a term I heard all the time people lecturing. And time again, what I would hear, and now I truly believe this is a bit of a myth. What the low hanging fruit is often said to dentists is your existing patients who are diagnosed who have failed CPAP. And right off the bat, you would think, yeah, those patients are the low hanging fruit. Those are ideal. They're already medically diagnosed. They tried a CPAP and it didn't work for them. They're going to be eager to get into something new. I'm going to challenge that paradigm a little bit because that is not my ideal dental sleep medicine patient avatar. And that patient still has significant barriers to get. The biggest barrier I have seen from new providers getting into dental sleep medicine is the medical billing aspect. That is, without a doubt, that's what stops the most best clinicians who have done the most CE in this from getting going. It's medical reimbursement. And just because your patient has a sleep study, just because they failed CPAP, does not mean they are immediately ready to go into an oral appliance and receive reimbursement from their insurance. So, let me kind of make a new paradigm for who the ideal dental sleep medicine patient avatar is. And this is who we go after in my clinic. So, if you're going to ask me, who do we quote unquote market to? This is who I'm talking with my physicians with. This is the relationship. This is the communication that I'm speaking with them in order to help me help them get their patients into treatment that is also reimbursed by their insurance. So, what you'll want to look up is if you look up Medicare standards, you're always going to be pretty safe going by them. Generally, they are the most strict as it comes to reimbursement is concerned. However, as you talk with your referring providers, you're going to want to know what they need to send you. And in an ideal world, it's just kind of one good handoff, get with their administrators. It may take a little bit of going back to get everybody fully trained. But if you're able to get everything that's on this slide to your office in one go, now you have patients that are ready to go into oral appliance immediately. The big thing that I would challenge you to get trust wise is if you can get patients with mild or moderate sleep apnea that prefer oral appliance therapy over CPAP. So, not necessarily failed CPAP first, that they are looking for an oral appliance as their first line of therapy. If you can build that up, that is the ideal situation, in my opinion. Don't forget, patients that fail CPAP, they fail it for a reason. A lot of times it's the pressure that does it to people. Um, the pressure on the machines, once they start getting over 10, that's when people will start tightening down their masks too tight, makes it uncomfortable. They may start getting some leaks in their mask, or they may um, just have some general discomfort with the amount of pressure coming into their face. Now, what we also know from the research is patients that require more pressure are not the best candidates for oral appliance therapy. So, if you were to say just off the bat that patients that failed CPAP are your ideal oral appliance therapy patients, you may be doing yourself a bit of a disservice, especially as you're getting started with new referral sources. The ideal patient is younger, lower BMI females. They are much more likely to succeed with oral appliance therapy than a blanket statement like failed CPAP. So, if you can start with this, it's going to go a long way to getting to this baseline normal so you have a good understanding of what oral appliance therapy is capable of. Now, normal pathway. What I aim to do clinically is I understand now that approximately 80% of my patients are going to do great with mandibular advancement device. They're going to be successfully managed with our pathway. So I do not want to spend all of my time on those patients. It's not necessary. I explain to my patients right away my approach to dental sleep medicine is I do have comprehensive kitchen sink full of tricks that we can help improve your sleep, but I want to start with the easiest solution for you because I know that's something that you're actually going to do and going to be able to stick to. If you give your patients three, four, five adjunct therapies and think they're going to stick with it right off the bat, they're just not going to. And you're going to get frustrated when you're not seeing success. And you're also not going to know what's not working. So I like to start with one thing at a time. So, my recommendation for you as you're getting started here is keep it simple. And that is extremely difficult for a lot of dentists. There's a lot of extremely talented general dentists that have spent a lot of time and money building up a comprehensive dental skill set. And from what I've seen in dental sleep medicine, it's not my recommendation to take the absolute comprehensive approach to every single patient. You may certainly find that's your niche. However, there's no way that you're going to be able to meet the needs of your sleep physicians. They will order anywhere from 100 to 300 CPAPs per month. What are you going to do when they start sending that many patients your way? Are you going to be able to handle it? From what I've seen in general dentist office that start incorporating dental sleep medicine, a nice busy office can incorporate about 10 appliances a month. That's somebody who's really got things going for them. That's great. If they really push it, for some reason, there seems to be a hard ceiling at about 20 appliances per month. I've seen it time and time again. To push through that 20 appliances a month, that's when you really have to start dedicating a significant amount of staff and time to this. So now in my clinics, it's not unusual for us to be doing 50, 60, 80, 100. I think our current high is 157. We just did that in December. And then because we have little kids, I take off from Christmas to New Year's. So I stop playing the rush game at the end of the year. The reason and the way we're able to do all of that is with a very good system and administrative workflows. Now, this is going to come at an absolute shock to a lot of people. Your new patient exam, in my opinion, this is only kind of a 10 to 20-minute doctor time exam. What are you looking for? You need to gather the necessary clinical information. And remember, these are all qualified patients. So this is our patient avatar who is diagnosed with mild to moderate sleep apnea. They want oral appliance therapy and they're being referred to your clinic for oral appliance therapy. So they don't need the amount of education that is typically needed in a patient that's sitting in the hygiene chair that failed CPAP, and now you need to educate them about their sleep apnea, why it's important to treat, and what an oral appliance is. That is a totally different situation. My experience when I was in the Army, and this was 100% free to the soldiers, it was extremely difficult to get somebody from the dental hygiene chair into my sleep medicine chair. And that's when there was no financial hardship to the patient. It's just a difficult thing to do. It is extremely easy when the patient is being referred to you for the treatments, because then it's almost like you're the endodontist. The patient has been told that they need a root canal. They're going to go to the endodontist, a root canal specialist. They know what they're going to be getting. They're going to get a root canal. Sounds good. Awesome. That's the flow that I've been able to build in my clinic. So, this new patient exam, it took me a very long time to get it down to this kind of 10 to 20-minute, gather the necessary information. When I first got started, believe it or not, my new patient exams were blocked off for 2 hours. I don't even know what I was doing with that much time looking back at it. But now that I'm seeing 150 plus new patients a month, there's no way I can spend that much time with it enough, that much time with each individual patients. And here, in my opinion, right now, for dental sleep medicine, digital records are an absolute must. The medical world works on a fax machine. That is their communication tool. You have to be comfortable faxing your notes back and forth. On my software that I use, I'm using a medical EHR. As soon as I hit go, sign my notes, it automatically gets faxed right to the referring provider. I don't have to do anything there. Also, digital impressions. I've spoken with a lot of labs, and they tell me the digital impressions consistently have better results. What I mean by that is they have less cases on hold and they have better fits to all the appliances. You want a lab that works well in the digital space. SomnoMed does a wonderful job with that. And these scanners nowadays, if you haven't looked into them, they have come down in price considerably. If you go the secondhand route, you can get a scanner that's more than adequate for dental sleep medicine for $5,000. Throw in a laptop for another $1,000 to $2,000. Under $10,000, you can be set up and going. If you want kind of the top of the line type of scanner, you're still talking less than $30,000 now. That is much, much lower than it used to be just a couple of years ago. Now, if you think about my clinic now, I am making records on all these new patients. So we're going to get a scan on them and I can keep that scan. So if they walk out the door and they say, "Hey, I'm not ready to go," then they call back 2, 3 weeks later, say, "Yes, I'm ready." I already have all the information. We don't have to do anything except have them sign the financial agreement and we're good to go. Now, with these patient workflows, what I love about the digital records is there's lots of scanners that can do this now, but you want to take a record of your patient biting down in MI and then also take your open protruded. And the majority of the devices now are very adjustable. That's one of the reasons I really like SomnoMed devices. They have plenty of advancement that you can do. You do not have to start your patients in too far forward of a protrusion and be worried about if you're going to be able to advance them all the way. So in my clinic, and this is just kind of a standard class 1 setup patient, generally I'm starting them pretty close to an edge to edge position. That happens to be about 50% of the total protrusive range for most people. And then I'm going to keep my follow up schedule very simple. So I am a fan of having patients titrate their own appliances. I'm going to be checking in with them to make sure they do it correctly, but I want them to be able to do it at home. So my assistants help educate the patients how to do that during their delivery appointment. Now, with SomnoMed devices, when you get to the delivery, in my opinion, these things just fit. The amount of time I'm personally spending during a delivery appointment is usually a minute or less. It's kind of a high five um, and realistic expectation for the patient. The assistants do the majority of that appointment. I'm just verifying everything looks good at the end. It used to be before digital impressions and milled appliances, a lot of times it would have taken 30 minutes to get an upper and lower tray fit. Now we can more or less hand these things to a patient and they're good to go. One of the things you want to do though with your patients, set them up for a realistic expectation. This is almost like a denture patient, right? So don't tell your patients you're going to sleep wonderful. This is going to be great on night 1, because that's just not the reality of what they're going to experience. What I like to tell my patients is, when you go to put this in, here's the key word. Here's another pearl. These are going to fit comfortably snug. So when it's fully seated on the teeth, it's going to be extremely comfortable to you. The SomnoMed has this B-Flex material that's able to hug the teeth really comfortable, but it does take a little bit to break in, about a week or so. When you go to take it off for the first time, it's probably going to take just a little bit more pressure than you're expecting, but that's 100% normal. After about a week, it's going to settle in and it'll be just fine. I do like my appliances a little bit more on the tight side than the loose side. It's very, and here's a great line, and patients accept this all the time. I'd rather have the appliances a little bit more on the tight side than the loose side. It's extremely easy for me to do a little bit of polishing on the inside of it and it'll loosen it up. It's extremely difficult for me to make it more tight if it's too loose. Plus, if it's tight nicely against the teeth, it's going to help with the long-term durability of the device. You say that and patients will love it. Next, I see my patients once they've been using it for approximately a month. So I have 2 appliances that are the workhorse in my practice. I'll show pictures of them in just a moment. It's the SomnoMed Herbst Advanced Elite and the SomnoMed Avant. I can manage, I would say, 9 out of 10 patients with those 2 devices all day. The only patient that will have difficulty is someone that may have an allergy to the material. That's extremely rare. I maybe see that once or twice a year, but that's extremely rare. Patients will ask all the time, if I have a nickel allergy, is this okay to use? Well, if you look up the epidemiology of a nickel allergy, 5 to 10% of the population should have it. So a lot of patients are getting these without even disclosing it. I don't know that I've ever seen a metal reaction, allergic reaction to one of these devices. Um, so very safe there. What I like to do at the 1 month visit is make sure the patients have been able to adjust it. So for our Herbst appliance, I keep it simple. I have done it every which way, and I have landed on this is the easiest titration schedule. Tell your patients to advance it 1 turn per day for the first 30 days. I've done it every which way. I said once a week, do 10 turns, once a week, do 5 turns, do 3 turns every 5 days. You want to keep it simple. If you do 1 turn once a day, the other thing that's going to do, it's going to help make sure your patients keep it balanced. Now, on the Avant, I keep it simple also. Once a week, move up a band. I want to see it in a month. I give them an instruction sheet on the titration. For the Herbst, I tell them not to go past the 4 millimeter mark. On the Avant, I don't want them to go past the 4 band. And if they have any discomforts that last throughout the day, certainly give me a call. What we're looking for initially this first month is all about just getting used to wearing the appliances. I want to know if you've stopped snoring. I want to know subjectively, does your sleep feel like it's better? And then what I like to do is objective dental calibration of the device. So what I'm doing in my clinic right now is I am utilizing dental calibration testing. I'm using the ResMed Night Owl for that. I really like it at scale. It's a disposable testing device, so you do not have to keep track of hardware. Patients can do up to 10 nights of study with it. I'm not using this diagnostically now. I'm just using it to help position the patient's jaw dentally so when we send them back to the referring physician, they're ready to go. So we're going to send them home with the ResMed Night Owl sleep test. I'm going to set them up with 6 nights of study. And it's going to be kind of based off of how they've been doing for that first month. So if they tell me the snoring went away right away and felt great, I'm probably going to do a total of 6 nights of testing, 2 nights at 3 different positions, and I'll probably back their device off a little bit. That'll give me a nice therapeutic window where they're at. If they tell me they're not sure, I don't know if I'm sleeping better or not, I'm going to test them where they're at currently, which is usually around 3. And then a millimeter forward and a millimeter forward. So we'll do 2 nights at 3, 2 nights at 4, 2 nights at 5. If they tell me, nope, I'm still snoring, everything's going bad, well, I'm going to say, okay, let me jumpstart this a little bit. I'm going to, in the office, advance their device a millimeter, and we'll test that 4, 5, and 6. So I give my patients a total of 2 weeks to get these 6 nights done. What's nice is the information gets sent back to me via a cloud portal, so the patient doesn't have to do anything. Hooks up right with their phone, gets beamed back to you automatically. Next, I'll do a phone call with the patient in approximately 2 weeks. And this is a 3-minute phone call. Uh, Reviewed your results. Looks like 3 millimeters the spot for you. Excellent. I'm going to send you back over to your sleep doctor. My staff's going to call you and set you up with a 6-month appointment. And that's it. That is very, very, very normal. 80% of my patients are getting caught in this net, and it's very minimal chair time. So, if you counted up all those minutes of how much time I'm personally dedicating to each one of these cases, it's probably under 30 minutes or so. And I'm not taking any shortcuts. And I'll show you some stats here in a little bit of how well my testing is going. I'm going to check in with my patients in 6 months. I want to verify that they saw their sleep doctor. I want to verify that they're using the device, that they're using the morning aligner, not having any side effects. If everything is good at this point, high fives. We're going to place you on annual follow up. If you need me, give me a call. Everything looks great. Annual follow up. This is just your chance to kind of touch base with the patient. Most of this 5-10 minute time, it's going to be how much of a social hour do you spend with your patients. This can be as short or as lengthy as you want. This is 100% up to you. This is just making sure your patients are doing well. There hasn't been any changes in their health history or their sleep. What's been extremely helpful now is the new weight loss medications. That has made it much easier to discuss weight as it relates to sleep apnea. So I have no issues anymore discussing weight with my patients. Hey, how's your weight been the last 6, 12, 24 months? Patients are happy to say, yeah, I'm having trouble losing weight. If that's the case, I can almost guarantee you have a weight loss specialist somewhere in your town. Get to know them. Give them a referral. Patients appreciate it. The other thing you're going to be looking for is it time for a new device? These devices generally last 3 to 5 years. It may vary by the payer how often they will be able to be replaced. Some payers, like Medicare, have a pretty strict 5-year replacement rule. Other payers, it can be as medically necessary. So you want to keep your rapport with your patients. Once you get them on kind of the second, third appliance route, it's so much easier. They're already an acquired appliance. You just get a new order from their sleep doctor. Easy as could be. So, device selection. I want to talk about this a little bit in this normal flow. And I'm spending a lot of time on this because you got to know what normal should look like so you can save your time for the advanced cases. Now, these are my two favorite devices by far, and I've used just about all of them that are on the market. The Herbst Advanced Elite, and remember, I'm not receiving any payment for this talk. The Herbst Advanced Elite is by far the best PDAC E0486 appliance on the market, in my opinion. That is a Medicare approved appliance. What's genius about this Herbst advancement is the arm is advanced by sliding across the upper member. Overwhelming majority of the rest of the Herbsts on the market, they're going to be advanced by lengthening that arm. When you lengthen that arm, that's a lever. If you remember back from your physics class, a lever at a pivot point, the further or longer out that lever gets, you're creating an exponential force at that pivot point. So I think that's one of the major reasons that we're not seeing as much breakage on these SomnoMed devices as other Herbst arms. In fact, I've never seen a SomnoMed Herbst arm break. The other big thing SomnoMed changed, and they changed this a couple years ago, if you haven't used them in a while, they used to have an issue where the screw would slide back. Patients would wear it for 2, 3 years, and they would just kind of slide back. You may or may not be able to see it on this image, but now on this wheel, they have a little metal indentation, and it does two things. It gives you a nice click as you turn it up. The other thing that it does is it prevents it from going backwards. So once upon a time, we used to have to put like thermocryl in the mechanism to keep it in place. I have not done that in years with these Herbst Advanced Elites. I am a huge fan of them. Do have them mill them with the hooks just in case you need to add elastics. Now, there's some research and there's some people that will say you need to put elastics on every Herbst. And while I agree that a lot of people do better with elastics, a lot of people also do not need them. So in my practice, I don't start with elastics. I want to keep it as easy as possible for the patient. We're only adding things on if necessary. When are elastics necessary? Remember, we're getting some sleep testing within a month to have a good therapeutic window. Patients are getting elastics on their device if they wake up with dry mouth, or we start seeing that we really don't like their sleep test numbers. That's one of the factors that we can change easily. If they're still snoring a little bit and I don't like their numbers, let's try putting elastics on your device and see how you do with it. Those night owls, we can do up to 10 nights of study, so it's easy to kind of experiment a little bit with those extra nights. With the Avant, same thing. Sometimes we'll put elastics on those, but it's not the go-to. The Avant mechanism, the way that it works is because it has that single front pivot attachment. If you open, it kind of slides the lower jaw slightly forward. Elastics are not as necessary in an Avant as they are on a Herbst. But from what I've seen in my experience, elastics are not absolutely necessary on every single Herbst. I only add them on when necessary. Now, let's talk about the chair saving time of these devices. The B-Flex material in there, that's the inner soft liner, is excellent. These things should be fitting with a good scan. Pretty much just put it in. Occasionally, I will use a light adjustment in the embrasures if it's a little snug, but it's extremely minimal work, minutes at the most. And that's just a light mark on the embrasures if it's too snug. What's great about the B-Flex is you do not need to use ball clasps. So a very popular way to make appliances is to make it with a all acrylic, hard acrylic with ball clasps. The hard acrylic is a little bit loose. You have some clearance there for comfort, and then you put the ball clasps in for retention. The danger there is the ball clasps will open up contacts on a significant amount of patients. So those are the people that you're going to be seeing on follow-up that start complaining, hey, I'm flossing my teeth and now I'm getting a bunch of food stuck here. A little pro tip if you ever run into that situation, this is why you want digital impressions. You can 3D print their original scan, make them an Essex retainer on that, have them wear it for a week or two. That'll close that contact up quickly. And then all these devices with their warranty, patients love that. It just makes them feel comfortable. 3 to 5 year warranty on these things, they appreciate it. Now, this slide is one of the things I'm absolutely most proud of so far. I really need to formalize and publish this. So, this is anecdotal data right here, but this is huge what you're looking at. So, this is just 250 successive patients in my practice. I spent, like a week or two putting this data together, and I was just going patient by patient um, of what I was seeing. And this was done when my area, these were all done on the 4% scoring rule. But this has been a very powerful tool as I'm talking about physicians. Because remember, there's a myth that oral appliances don't work that well. Well, what do physicians believe? They do believe in Inspire. They do think that works well. If you read the STAR trial, how Inspire was FDA approved, they defined surgical success as a 50% reduction in AHI and a final AHI under 20. If that is our mark to hit on oral appliance therapy, we're nailing it. We're hitting it out of the park. Every single category of patients. Now, here, there's only 19 severe cases in this group. I don't get as many severe cases again because I've kind of trained my referring doctors to who my ideal patient is. So they do send me a significant amount of mild to moderate first line treatment. That's the bulk of my practice. But even if you look at the moderate to severe, we're doing very well. We're going to see in the ballpark 75, 80% success rate with these patients. So when my patients ask, what are the success rate? I'm able to show them right here in my clinic. This is what I see. Statistically, you should fall in this category. Now, we're going to individualize it for you. We're going to do our follow up to make sure you're here. If you happen to be outside there, we're going to help find you where you need to go. But these are the statistics. What this is also going to help you understand is dentistry is extremely personal. We can't help but think everything that we do is a little piece of us. Uh, If an appliance is not working, it's extremely personal. Oh, what did I do wrong as a dentist? What do I need to do? What can I do procedurally to fix this? And remember, this is a therapy. Not every single patient is going to respond. Sometimes it's your job to recognize that and get them where they need to be. I'm going to be showing you a case like that later. Start collecting this data on your patients. This is what you're going to want to be showing your physicians. This is what's going to help you build trust and that you know what you're doing. So, next, let's get into how are you going to be able to identify the non normal, non responder, undertreated patient? Because remember, what we've spent the majority of this talk on so far is we wanted to know what normal is. I see the bulk of my patients normal so that when I need to dedicate excessive time to a patient, I have that time available for these people. So let's look at some unique cases. What do you do when an edentulous patient walks into your office? Now, there's a couple of different ways you can manage this. When I first came to SomnoMed on this, I see they have an edentulous Herbst that they can make. I kind of asked them on the workflow for it. They gave me this nice PowerPoint of how to do it, but my goodness, it was 5 appointments of the full denture workflow, wax rims. Um, and I thought there's got to be a better way than this. I'm very knowledgeable in how the digital denture workflow is going. And in my world, I was thinking, edentulous maxillary, partially edentulous mandibular. The mandible is going to retain this great. And the maxilla, can I just send this case to you digitally like this? And are you going to be able to make me a Herbst Advanced Elite? Now, unfortunately, right now, this is not enough information for SomnoMed. One, they're not making the Herbst Advanced Elite milled in edentulous yet. Um, my understanding is it has to do with the puck sizing. It's just not adequate for this workflow yet. So these are still handmade. But what information is missing here is the Fox plane. So they don't know where to put that occlusal plane, which you'd usually capture with your wax rims. But I was thinking, man, there's got to be a better way to capture that information. Now, these patients, I do like to scan their existing prosthetics. Scanning dentures is a little bit of an art form. Depending on which scanner you get, they keep getting better and better at it. Another little trick that you can do is if you have a CT scanner, you can throw it in your CT machine and convert that DICOM into an STL. There's tutorials on how to do that. Now, take a look at that lower partial. That is not what it looks like in real life. That is not an accurate scan of that. So, as you're using your scanners, you have to know what your limitations are. Now, a lot of people will recommend just make the appliance over their denture. Okay, I have a couple of issues with that. One, I'm not making these patients dentures. The last thing that I want to do is have a denture break in the process of taking it in or out or while they're wearing their sleep appliance. 100% of the time, you'll get blamed as the bad guy for that. And then you'll be on the hook for a new denture and a new sleep appliance. I've also made them over partials or dentures before where the patient ends up getting a new denture. And then guess what? They automatically always need a brand new sleep appliance. And sometimes, if the patients get a brand new cast partial, those are a nice investment for a patient. They may not be too eager to be investing in a new sleep appliance. So, for that reason, I like to make them directly on the tissue. The other thing that can happen with dentures is these really need to have a nice seal. We're going to be putting a little bit of force on it, so I want to make sure it's a really, really well-fitting denture. If it's not a well-fitting denture, why would you even make it over it? You're just going to have failure where it's not going to stay in place. So I've come up with this system now, and I've done it multiple times. Um, and gotten excellent results with SomnoMed. What I do now is I will 3D print a duplicate of their denture that I've scanned. I'll usually relieve a little bit of the inside surface depending on how well or not well fitting the denture is. And then I'm going to use this, and it's going to give me two pieces of information. One, it makes an excellent custom tray. It requires minimal border molding. You can pretty much just do a wash impression with this, and you're going to get an excellent, well sealing denture. Two, I'm going to have SomnoMed follow the existing occlusal plane as the Fox plane. So now I have no more need for an occlusal rim. I don't have to mess with any wax. That's a huge win in my office. SomnoMed's still going to want to pour up a physical impression for these because they're going to be handmade and they have to be articulated. So when you go to make your bite registration, you do need to do that in an analog way. So remember, they're going to pour up the impression. So you want to take your maxillary wash impression first, then take your bite registration. And be mindful, depending on what they have going on the mandibular, how much thickness you need so they're going to have a nice stable bite. This is all the information that SomnoMed needs to make a nice appliance. Typically, in the situation where it's a partially edentulous mandible, I will scan and 3D print that because that's going to be retained by the teeth mainly. So that when I'm comfortable scanning, I'll 3D print them a model and send it off to them. I have done this a significant amount of times now, and the fit has been excellent. You are still going to need to prep your patients. This is a denture. All dentures, no matter how well they're made, are going to have some sore spots. You're going to have to bring the patient in to do some adjustments. Use whatever you're comfortable with, whether it's pressure indicating paste or occlude spray. Expect to have to do a little bit of adjustments on it, but the seal on these things are fantastic. This is an excellent way to do this, and you can get it done in just 2 to 3 appointments now instead of going through the full 5 appointments with a wax rim that you have to get made by a lab. This has been excellent for me. I've done it numerous times now. Very predictable. 10 out of 10. This is the way to do it versus wax rims. Next, let's talk about a high curve of Spee patients. This is where we're going to have to start potentially making some compromises. So, within dental sleep medicine, something that often gets taught is that it's an absolute requirement. You must scan the distal of the teeth. What I have found is that's not necessarily true, especially with these SomnoMed B-Flex devices. They fit the teeth milled so well, you're not really going to see anything open up. A small chance, I suppose, on the mandibular distal that you may open up a contact, but it's excessively rare. I do not stress about having my distals wrapped at all. If they are, great. If they're not a big deal. If it's going to cause a retention or path to draw issue, I'll remove it. That is not a problem for me. But check out this patient. If you are going to use SomnoMed's normal, just kind of like 3 millimeter clearance, remember that's 3 millimeters from the lowest cusp tip on the maxilla to the highest cusp tip on the mandible. So if you look at this tooth number 32, when it's in occlusion here, it's almost up to the total gingival line of the anterior teeth. If you want absolute clearance there, this patient is going to have to be opened up 15 plus millimeters in the anterior. In my opinion, that's way too much. If you underdo this, and if you were to send this in and say you must wrap the distals, you're probably going to get a note back from SomnoMed saying, hey, we need to open this up another 10 millimeters or something kind of ridiculous to even capture that. In this case, you're going to have to make some compromises. You're not going to be able to cover all of those distal molars. So on my lab script, I am going to give the lab permission to not extend the device distally due to vertical dimension issues. Um, and that will be okay. Sometimes you have to make that compromise if you want to do the case. Alternatively, with this patient, you could send them to go get the third molars extracted. That's always an option too. To fix the curve of Spee totally, you're talking about some pretty invasive orthodontics and or orthodontic surgery. I don't have too many of my patient bases running out for that. Check out, here's another one. Again, it's always kind of these third molars that get drifted into odd spots, or a second molar drifting into an odd spot that can create something strange. Now, this patient, if you look at this tooth in the lower right, it's kind of a key tooth. It is holding these maxillary molars in place. My concern is if we were to cut this device short, that we would have some extrusion of these teeth that would set an extreme problem for this patient. If that happened on this patient, I just tell him, yeah, you had a good run with your third molars, time to get rid of them. This patient, though, it's going to be a problem. So this person is going to need some significant advancements. You're going to have to pay attention to where the occlusal plane is going to be. Visualize it in your head. Is there enough room here all the way around for clearance? This person's opened up, a pretty good amount. I wanted that though because I wanted to make sure there was some coverage on that distal tooth. So you're going to have to use your best clinical judgment when you're looking at these high curve of Spee. Expect to have some communication potentially with the lab too. If they tell you, remember for every 1 millimeter of opening in the posterior, you may need 3 millimeters of opening in the anterior, and that's with a normal occlusal setup. With an abnormal occlusal setup, those numbers can be exaggerated. Next, appliance selection. This patient. So remember, I'm not a general dentist. All I'm doing is dental sleep medicine. This patient happened to be a vet. They were on an extremely fixed income. And if you notice here, look at, there's a little bit of silver in there. What is that? Well, that's some titanium. This patient specifically got some implants placed, not just in the United States, and they cannot find a dentist in the US to restore them. So they have some implants just kind of sitting there. They have some extreme wear. One of the things you have to start thinking about is appliance selection. And this is one of the reasons why I love SomnoMed B-Flex. I got to tell you, retention doesn't even cross my mind. Now, if you were thinking of doing this case in nylon, if you're doing it with a nice nylon lab, they should be getting on the phone with you and saying, hey, doc, these crowns are really short. I don't think we're going to be able to get good retention with this. You're going to struggle mightily to get good retention in nylon with this. If you go all hard acrylic, that's also going to be a challenge. You have to absolutely nail the retention slash B2 retentive. Otherwise, there's absolutely no retention and the things just fall out of the mouth. What's so nice about the SomnoMed B-Flex materials is it's an acrylic with kind of a silicone property. One of the things that gets taught within dental sleep medicine is avoid soft liners. I know they use soft kind of with this. I would not consider B-Flex a soft liner. It doesn't really behave that way. It's more of a comfortable acrylic. It's an acrylic with a little bit of silicone properties to it. If you look closely at this Herbst Advanced here, you can see now this notch in it. This is what's helped prevent that backflow in it. When you're using a B-Flex device, I don't even consider retention now. So next, let's kind of look into how are we going to identify our undertreated patients. So remember, in my clinic, I'm kind of wanting to do speed. I want to identify, is my patient a responder? Do we need an adjunct or do we need a different therapy? And I want to be able to get that back to my referring physicians relatively quickly. This patient saw me during the CPAP recall that happened. They do have significant disease, moderate getting towards severe sleep apnea. BMI is not an issue for them. Um, we went ahead and fit them with the device, did multiple nights of sleep study. And this was after 1 month. At 1 month, they tell me, Dr. Pagano, I'm still sleeping terrible with this thing, waking up all the time. Like I was doing better when on my CPAP, but I don't want to go back to those after the recall. So I'm looking at their data here, and you can kind of see this progressive getting worse as we advance. Let's look at the data a little bit. So the mystery is in the history. These night owls, they do not give us a ton of channels, but they give you enough once you know what you're doing. So if you look at this sleep study, look at that first night. They nailed it. What was it about that first night that looked great? So when they finished the study, it has them do a little bit of a survey. This patient happened to noted this. Look at that. He slept on his side, not his back. Looked great. Next nights, they started getting worse. Tossed and turned the whole night, threw in some alcohol. That's going to make the studies worse. Okay, this is starting to get me think maybe there's a positional aspect to their apnea. Let's put on some positional therapy. So what I did is I had them pick up a slumber bump. This is a device, kind of like a fanny pack that you're going to wear. Has a pillow in it. Just makes it extremely difficult to roll on your back. Then we set them up with a sleep study that does do positional therapy. And look at that. Boom. We got them treated right away at that 4 millimeters. That's where they felt like they were sleeping the best. 4 millimeters. They were doing well, keeping them off their back. And now we've confirmed again, yes, that's what they need. This made this case from something that could potentially be extremely difficult to extremely simple. And that's due to this serial home sleep testing that I'm doing. If you did not do this, let's look back here a little bit. Let's just say you saw them and they happened to advance to 7 millimeters, 6 millimeters. More forward is better, right? You do some testing on them, like, yeah, it's better, but it's not great. You send them to your sleep doctor. They're going to say, yep, see, they're all the way advanced and these don't work. Well, you didn't do your full due diligence here. You have some evidence that shows there's something else going on. Even though the night owl doesn't give us positional therapy, we can still infer it and then confirm it using a different test. Let's look at another patient. This guy, you can just kind of see the history here. We got him treated well. His only complaint was his metal arms were kind of bothering him. But that's okay. That's an easy fix too. Move him into Avant, easy. Next, you want to be able to identify your non-responders. Your physicians are going to be looking for that communication. Not everybody responds to CPAP. That's okay. Not everyone's going to respond to oral appliance therapy. That's okay. What our job is as the doctor is to recognize that and get them where they need to be. So here's a patient, moderate sleep apnea, history of AFib, and failed CPAP. Okay. We get them into a Herbst Advanced Elite and we do our 1 month follow up. And these are the results that we're looking at. These are bad across the board. Nothing is good here. We're going in the wrong direction. Okay, sometimes people do need some more advancements. I didn't see any evidence of any type of positional therapy or anything like that. Let's do some more advancements, and it's still bad. So now we've done extreme due diligence. We've done everything within our power to kind of set them up for as much success easily, but they just don't seem to be having it. So now, when I go to have this conversation with the patient, look, I'm a big fan of these oral appliances, but there is a group of people that they just don't work with. And the good news is we found out quickly that this is you. Now, my major concern is your heart. That's why you're here. I don't want you to go back into AFib. So, are you open to the idea again of trying CPAP? And at this point, patients have tried lots of things and they're reopen to the idea. So now you're setting your sleep doctors up for success to where if you've identified a non responder, you've had the discussion with them what the next steps can be. Try CPAP again, maybe try a couple of different masks. If weight loss was applicable to you, let's get you to a weight loss specialist. And then also now, don't write off Inspire. Um, for the patients that qualify for it, that get it, it does have a very high patient satisfaction rate and it can be effective for patients. Your sleep doctors are going to recommend it if everything else is failing. So have the conversation with the patients, kind of prepare them for that. That's going to help you with your communication and trust that when your physicians refer you a patient, they know you're going to manage the case right. A lot of dentists will take a case like this and they'll drag it out 4, 5, 6, 12, 18 months before they're ready to throw in the towel. And that's just too long. You don't want to mess around with that. So now with a little bit of time left here, I want to go through a couple of clinical pearls that I've picked up over the years. One, get a Som gauge. SomnoMed sells it. They're not expensive. What they have is 3 millimeter bite fork. So that's going to give you your minimum distance. And then in the front of them, they have a little ramp. So if you want to increase the VDO, it's extremely easy to do it. The gauge themselves can go through the sterilizer, and the bite forks are super cheap. I highly, highly, highly recommend, no matter which device you're using, this is my go-to bite fork. I even use this for most night guards that I make as well. Next, clinical pearl. If you're not interested yet or you haven't started it yet, start looking into 3D printing. I love 3D printing. It makes me excited. I love showing it off to patients. Patients appreciate it. It gives you a little bit of freedom that you can't get otherwise. Remember, my partner, he's an oral facial pain specialist. We do see a lot of patients with headaches, clenching. We'll make them some orthotics a lot of the time. The trouble with those patients is they tend to break everything. So if you can rapidly reproduce something or get them into a different type of splint, that's really beneficial. Plus, as you get even more advanced, you can use this with a little bit of your dental sleep medicine. So I practice in Virginia. There tends to still be a really high smoking population here. A lot of people make your morning aligners in this fashion, boil and bite kind of things. These get really gross really fast. It's not unusual for these to be walking into my clinic from other providers looking like this. I started 3D printing these a couple of years ago, and we were back and forth with my partner on this, and we started charging for them, right? At first, we said you could get this free one boil and bite, or we can make you this really nice one 3D printed. We charged a small nominal amount for that. And what we found is the overwhelming majority of people wanted the 3D printed one. So then we like to just kind of have our way of doing things. We just said, you know what? Everyone's going to get a 3D printed morning aligner. They hold up better. They don't distort. They're easy to keep records. And if a patient loses it, we can rapidly make them a new one exactly how it was. There's lots of advantages to it. We've been doing that extremely successful. The other thing that happened is when I started charging for them, I swear my compliance with patients went up. Funny how that works. And then the other thing that's fun with 3D printing, it just is fun. It helps you enjoy what you're doing. You can personalize these things a little bit. I grew up in Wisconsin. I'm a Bears fan, but I did have one of my buddies come out and visit me from Wisconsin. So I made him a custom G one here. I treat a lot of veterans. Sometimes I'll throw in a little bit of symbols into their stuff, see if they notice it. If you're going to get into 3D printing, though, just make sure you follow the instructions. The stuff all has to be biocompatible. You want to polish it up so it looks nice. And here's my last little pearl for digital printing that you should take away from this. This patient came in, new patient appointment. That's the before. They had ortho, lost the retainers. A teeny tiny little diastema opened up between 8 and 9, and it drove them nuts. So what I did is we scanned them for their records. I digitally moved those teeth a tiny bit, right? Not a lot, just a little bit. Made them an Essex retainer, had them wear it for a week. Came back in. You can see we scanned them at that point. It nicely closed that diastema for them. They were thrilled. They thought I was the absolute best dentist ever, and I really didn't do that much. And then if you run into this side effect of minor tooth movement, it's really nice to be able to get yourself out of a little pinch here. Um, so this is what I have created at this point now. This is what I walked to into my lab on Monday. It's not unusual for me to walk into a lab like this. If you don't know what you're looking at here, each one of these is an individual patient case. My goal is to make oral appliance therapy as accessible as CPAP is for my referring physicians. The only way you can do that is to create a nice system to manage this at a population level. So that's my goal. I want to thank you all for having me on and taking the time. If you have any questions, we'll take a look at the chat and be happy to get those answered.
Michael, that was amazing. So detailed and helpful of all those pearls and clear thoughts to help our colleagues get into this and really do a lot of good for their patient population. So I have a question. A couple of questions have come in. One
Yeah.
of them ask about because you emphasize billing at first, and one of the things you mentioned there was the minutes that doctors are involved. Well, there's kind of two parts to that. Well, it's really great when doctors don't have to spend a lot of time, but if we're billing medical for the time, well, then we don't get to bill very much. So can you talk about that just a little bit?
100%. So, what I recommend you look up, and this is put out by the AMA, American Medical Association. If you look up, there's a PDF on it, um, CPT 99205 guidelines. If you kind of Google search that, you'll get to it. And there's about a 15-page PDF that will outline how the AMA wants you to code your appointments, and they changed it a couple of years ago. It used to be on this point system. They changed it a couple years ago to include either time or kind of a medical necessity slash complexity. So, one way to do it is through medically necessary time. Now, the key word there is medically necessary. Just because you spend 2 hours with a patient does not mean that's medically necessary. If you're only there to talk about, you know,
Voting.
some minor soreness, it'd be inappropriate to bill for 2 hours. However, it's not unusual for doctors to spend an hour for their first appointment, and they may bill 99203, 99204, 99205 based on time, as long as it's medically supported. The alternative to that is by billing based on complexity slash medical need. And if you read that document put out by the AMA, you'll be able to see, is it a acute or chronic issue? Is there surgical indications? Do you personally need to order or review any tests? So just reviewing the sleep study with a patient doesn't really fulfill the need of reviewing a test. Um, but go through that document in detail. It's well laid out. It's only about 10 or 15 pages. It's put out by the AMA, and that will answer those questions.
So that let's make sure that they got that reference. It's by the AMA 99205 PDF or something like
Yeah,
that.
I'll get that link out to you guys to make sure that we have that.
Okay, that'd be super helpful. Everybody loves to be able to get access to those kind of resources.
Yeah.
So, you mentioned elastics a little bit. Say a little bit more about that because you alluded to that the research that shows elastics are necessary, but then in our practical practices, as we both know, the elastics aren't always necessary. So, talk a little bit more about that.
Yeah, excellent point there. So, it's our responsibility as the physician and the treating doctors here. um, to understand and interpret the literature as it applies to our patients. Now, statistics is something that does not come natural to people. A fun fact is calculus was invented before statistics. That's how much our brains don't think about it. So, with all of this dental sleep medicine research, over the last few years, there's been a lot more done, but it's still not to the extent where you can make rock solid statements, in my opinion. So, the research that supports using elastics, from what I can see, they simply don't have a high enough, the term is power. What that's referring to is how many participants are in the study to be able to make their conclusion definitively. What I have seen in my practice is there's a large segment of patients that don't need rubber bands. So it's absolutely not that every case is improved with rubber bands. There's select cases that do have significant improvement. I like to keep things as simple as possible for my patients. We're doing good follow up with my patients, so I have no hesitation not adding it unless necessary. If you think you're going to have difficulty with follow up for one reason or the other, that may be something you want to bring on board right away. But for me, I keep it as simple as possible. Only add on what we find to be medically necessary.
Do you ever use anything for dry mouth? You mentioned that a couple of times. I know in my practice, I use a quarrel quite a bit. How about you?
Oh gosh, dry mouth is a really tough one. It depends what's causing it. If it's medication based, depending on their medication, you may want them to ask their primary care if they can adjust any of them or not. If it's due to like a radiation, you're going to have an extreme difficulty. Anybody, and I'll prescribe this even though I'm not their general dentist. If anybody has dry mouth, I will prescribe them just Previdence, just as our basic dental due diligence to help reduce their caries risk. Um, if you can, those are the patients too where I will recommend some mouth taping. Now,
Mm.
mouth taping, when that came on the scene, I don't know, 2019, 2020, I feel like is when we started hearing a lot about it. I thought that was nuts. When I first heard it, I thought there was a 0% chance I'm going to tell my patients with a breathing disorder to tape their mouth shut. Like someone's going to find them in their bed in the morning having a stroke and they're going to blame me for taping their mouth shut. Now, what have we found? Mouth taping can be, in select cases, beneficial if people are having difficulty either getting lip patency and that's causing dry mouth. Also, we didn't get into this in depth. Those are also the patients to start investigating. Do you need to see an ENT? So again, in my practice, I don't do the kitchen sink approach. I do the medically necessary approach.
Mhm.
So if you start having a lot of dry mouths, we'll add elastics. I'll try some Biotine products. We try some mouth taping. If none of that can check, how do you feel about seeing an ENT? We can get some ENT, see if that is going to benefit you, increase the nasal patency to alleviate it that way.
Very good. I'll put in a little plug for my favorite material called a quarrel, which is a medical grade xerostomia product that's coming into dentistry now too. It's lipid based, so it's a lot more effective than all my water based ones I've used before. So
Oh, that's great. I haven't used that one yet.
I'll send you some information about it. All right. So that is all the time we have. We got to most of the questions. And honestly, Michael, there weren't very many questions because you were very thorough in your explanation. So I applaud you for that presentation. Thank you so much. So everybody, if we did not get to a question, or if you have another one, well, please send it in and we'll get that answered later on. Within an hour, we'll send you a link to the replay of this presentation and instructions on how to access the CE quiz. Please be sure to complete the free CE quiz associated with the webinar to receive your continuing education credit. Thank you, Michael. That was excellent. Thank you. And our sponsor, SomnoMed, they've been behind good education in our field for a very long time. So I appreciate this additional support of our profession from a very great company. So thank you, SomnoMed, for this. And I'll say goodbye from MedMark Media and Dental Sleep Practice Magazine. And I'm Steve Karstensen. Thank you.